Well, good morning. I'm grateful for an opportunity to share a little bit about missions with you today. This is actually the remake of a video presentation that was done May 19th of 2018 at a live event that we did under the Medical Missions 101 gathering in Plano, Texas. I wanted to have an opportunity to kind of go through that material again with those of you who may be watching now. Because we had some audio issues on that presentation, and I wanted to make sure that we were able to capture everything, that we were able to get you everything in this course. So I am, as I said, grateful for an opportunity to share a little bit. But specifically for what we've learned in the last 2 decades of really studying medical missions, but studying from the other side. My wife Candy and I are both nurses by training, and we're the founders of an organization called the Christian Health Service Corps. You probably, if you're watching this, probably know a little bit about the Christian Health Service Corps. But we are a mission organization that specializes in sending healthcare professionals as long-term missionaries. In fact, we're really the only mission organization that has that specialty of really focusing on sending, supporting, and caring for healthcare professionals as long-term missionaries. Some of our programs would include a women's health and fistula surgery program in Angola, run by Dr. Priscilla Cummings, pediatric plastic and craniofacial surgical program in India, a severe acute malnutrition referral center in Eastern Congo, run by Dr. Lindsay Cooper, community health development training programs in Cote d'Ivoire and in Uganda, a physical therapy school put together by Carrie Moss in the Ukraine, and we train surgeons in a number of different sites. In fact, central to, I think, our identity as an organization is that that many of our folks are engaged in training and equipping local healthcare professionals to be providers and maybe even missionaries in their own context. And we also are working with a couple of family practice residencies programs. We're trying to get one started in Ethiopia and an existing program in Kenya under Kabarak University. Some of our folks are teaching in that program. Well, these are just a few of our missionaries serving around the world. I'm often asked what I really do with the ministry, and I have to say that I'm pleased to say that I have an opportunity to minister to and be in maybe somewhat of a pastoral figure to 50 families serving around the world and doing some amazing work. Some work in really hard places, some places I can't even mention on this video since it'll be on the internet. But Verlin Anderson there in the middle is a good, Verlin Anderson there in the middle is a good example. He and his wife Debbie were in Cote d'Ivoire throughout the Civil War and raised their children there during that time. So our folks really see some tough spots and some tough places. So I'm not sure if you've ever been in a mission hospital, but this is a good example. This is the maternity ward at Kalakembe Hospital in rural Angola. Dr. Daniel and Dr. Priscilla Cummings serve with us at this facility. Priscilla is a board-certified OBGYN with specialized training in fistula surgery, and Daniel is a board-certified ER physician. They are the only 2 doctors for this 200-bed hospital. Now, many of our missionaries are standing in the gap to keep places like this open and the Christ-centered compassionate healthcare they provide available. One thing I want to share, is it's estimated that about 50% of healthcare provided in sub-Saharan Africa come through Christian mission hospitals and health programs. And I would say probably 70% of the functional healthcare that comes through comes in is delivered in sub-Saharan Africa, comes through these programs, and that's just so vitally important. The sad thing is that many of these hospitals are closing because the denominations that founded them are largely no longer supporting them. More than 200 hospitals in India, Christian hospitals, have closed in India in the last decade alone. Now, some of that is just kind of what's happening governmentally there, but a lot of it is just it's really hard to support hospitals in a context where their only payer base may make $1 or $2 a day. The other thing that many of you may not be aware of is there's only about 1,300 full-time medical missionaries left serving around the world. And that's not very many in the context of the hundreds of mission hospitals that are fighting for survival. So how did we get started on this journey? And how does that relate to, improving access through mission hospitals? One thing that we realized, we started doing short-term mission trips with our church many, many years ago. That's where we started. That's how we got involved in missions, and that's how many enter missions. But I remember my first mission trip and just being, really looking into the faces of young children who I knew were malnourished and likely may not survive through the next bout of viral diarrhea or severe illness. Knowing that really moved me, and I knew that God used that time to really shape my thinking and my understanding of missions. But we also knew that there was some inherent problems with the way the church was oftentimes doing short-term missions, setting up in churches or schools to provide primary health care. So we began to ask a lot of questions, and we began to ask questions from the other side, from the receiver side, and what do the medical teams that are going out to do work really look like? So we spoke with local hospitals, medical schools, nursing programs, many clinics, and long-term missionaries. And what we found was really grew our understanding of missions a lot. And much of what we learned on that journey we put in my book, When Healthcare Hurts, an evidence-based guide for best practices for global health initiatives. And we shared in that book a lot of case studies and a lot of kind of what we learned from looking at things through the filter from the other side. Understand that there are two worlds in medical missions, and when we look at short-term missions as a whole, not just medical but all kinds of short-term missions, see there's about 4 million of these groups and individuals rather that leave as participants in a group, leave the U.S. every year. 4 million. Short-term medical volunteers we estimate to be 250 to 400,000, probably roughly 5 to 10% of that total number. But that is still a huge number of short-term volunteers going out into the developing world. They often set up in churches or schools to give primary care. Now, on the long-term medical mission world, we know from a few different sources that have looked at this, there's probably only about 1,300 full-time missionary providers out there serving around the world. Hundreds of thousands of mission hospitals, or hundreds if not thousands of mission hospitals fighting for survival. And they provide 50% of the care in sub-Saharan Africa and large amounts of care in many other developing communities around the world. And we know that many of these hospitals are closing. So what would it look like to bring these two worlds back together? And I think that's a question we really need to ask. Unfortunately, these two worlds don't work together very often or very well sometimes. This picture that you're looking at here is a hospital in rural Haiti. In 2010, after the earthquake, there was a mandate, government mandate, that went out of, and that was that all healthcare was to be provided free of charge for at least the next several months. Now, this is what transpired. They were able to sustain free care for up to 3 months, but after that, it really began to stretch. Well, it began to stretch everybody from the beginning financially. So when the hospital started charging again, they soon found they had very few patients. This particular hospital in rural Haiti, about an hour and a half inland from St. Mark, found that they went from 100 outpatients a day, paying outpatients a day, to only 10 to 12 patients a day after they started charging again. So what happened? The answer is that there were so many volunteer medical teams providing care in the area that all of their patients were going to places where they could get free care and free medications. Now, the short-term teams working in the area had no idea they were having this effect. And they were really well-intentioned, and they had a strong desire to help, not hurt. But sometimes this is really what happens. This is an example of unintended consequences. Robert Merton was the first to propose this idea of unintended consequences of proposed action. He's a social scientist. And it's basically that social action to improve the quality of human life, respond to human need, often has unintended consequences. And they're consequences that we really have to pay attention to. Dr. Paul Farmer and Dr. Arthur Kleiman do a summer course in global health at Harvard University. And one of the main underlying themes is this idea that there are unintended consequences to our actions many times. I'm going to make available in this course, you'll be able to click, there should be a place where you can click a download of the case studies we did in the live event, where people had an opportunity to really look at some actual case studies and discuss them and try to maybe create some solutions to some of the problems that we've seen. But I want to share one with you quickly, this Maria's story. And Maria is a great example of this idea of patient safety in global health. Maria was a 29-year-old girl who brought her 4 children into the clinic, I think 5 with the infant. So 4 children and her infant, 5 kids, to be seen by a local by a visiting physician in a rural Central American village. Now, she received 3 of them were ill, so she received prescriptions for 3 of the children for antibiotics. She also received prescriptions for vitamins for them all, and Tylenol for 3 of them that were ill, including the baby. So she took that handful of prescriptions after she saw the physician, and she took them over to the pharmacy counter, a table that probably looks much like this, or 2 or 3, and handed them to a paramedic who was then charged with filling those with an unlicensed non-medical volunteer, and they got all of these medicines in Ziploc baggies. And then they brought her back to the counter, where she stood in front of a crowd of people and tried to keep her children from getting lost in the crowd, and listen to instructions for each child, for each medication, that were given through a translator. Does anybody see a challenge with this in the context of patient safety? Obviously. But that wasn't the main She then took them back to her one-room dirt floor home, where there was nowhere to store these medications away from her children. But the big issue here was she didn't fully understand the instructions. A week after this team left Central America, she arrived to the public hospital in Santa Rosa, Copan, with baby and fulminant liver failure, and after having been given an overdose of Tylenol for the entire week. She had mixed up the dosages. And that is, I think, a great potential in this area of global health, where our good intentions can cause harm in the hospital Haiti context, in the development perspective, and in the patient safety concept in this context. So there's a number of these studies, some of which were good studies in this document. So some good examples as well, not just bad examples, but some good case studies that we've collected, some bad case studies that we've collected, so that you can really review this content and really kind of, if you have a group that's going to share some of these, please feel free to share the case studies with them, so they too can learn and grow, and we can figure out strategies to do really good, healthy medical missions. Now, I'm convinced that 90% of the problems that happen with short-term mission teams, both from the construct of development and patient safety, really could be eliminated with one thing, and that's kind of engaging the local health system and being part of a long-term work, not being out on your own or being connected to a local pastor or somebody who invites you to do work in a community that doesn't really have a good sense of the medical system in that region. Also talked about when healthcare hurts, we have this idea that when we're trying to help, we have all of these underlying potential unintended consequences. But we can develop strategies around those, and that's what the book is really about. But there's two, I would say, pillars of best practices, ultimately, and those are, are we supporting and promoting human dignity in the context of what we're doing to respond to human need? And then number two is, are we supporting and promoting patient safety in the context of healthcare delivery? We can further break those two pillars down into a few different areas in best practices. We have patient safety, healthcare system integration and collaboration, and like I said, I believe this one particularly could eliminate a lot of problems. Community empowerment, engagement, what does that look like in the context of short-term? In health facilitation of health development, in other words, are we helping improve the healthcare delivery there, and is our presence doing something to raise the standard of patient safety and the quality of care provided? In many instances, it can, if it's well thought out. Now, these four kind of areas that I'm mentioning, they really are highly interdependent, and as you begin to study them, you will find that there are a lot of good strategies for improving the quality of care that we provide, for facilitating health development, for engaging the community, and a lot of that is spelled out a little bit more detail in my book, And When Healthcare Hurts. So what are some barriers to patient safety in global health? And there are a number, but probably the two most preeminent ones are, that most medical teams want to provide care in a church or a school or a place, ideally, that wasn't really structured for health care. And that's probably one of the biggest problems that we see. Surgical teams often operate in facilities that lack a really good surgical infrastructure. In other words, they take their surgical care and move it into a hospital or a clinic that doesn't have a good surgical infrastructure or post-operative care, or even a PACU. And all of these things have been real challenges for medical teams kind of wanting to do good in global health. Now, the Donomedian model is the model or framework that World Health Organization uses to really explain both patient safety and healthcare quality improvement globally. And if you look at this, really what it's saying is that There needs to be a process by which healthcare is provided. There needs to be a structure through which healthcare is provided, and that needs to be a structure that normally, through which normally healthcare is provided, and then patient-centered outcome assessments. So this is really what it takes to achieve some level of patient safety. But this rarely exists in the context of a primary healthcare team setting up in a rural community. There's also some harmful assumptions that we have to break free from. You know, anything a medical team can offer in their limited time is beneficial. This is, you know, sometimes seen as something's better than nothing, right? And that is certainly a major challenge that we have to get past as a medical mission community. Second is, because we have limited time in this community, our emphasis should be on the quantity of patients we see and not the quality of care that we provide. And nothing could be farther from the truth. From a patient safety perspective, there are a lot of challenges. You know, just in the Maria story alone, we can pick out that non-medical church volunteers are often used to fill prescriptions. And instructions are given to translators by a nurse or a paramedic. And oftentimes these are in front of a crowd of people, in front of a pharmacy counter. Caregivers of children may receive several prescriptions, usually in Ziploc baggies, not child-resistant containers, often receiving instructions in front of a crowd, as I mentioned. Those same caregivers then can take those baggies home to their one-room dirt floor home and not really have anywhere to store them away from their children. And the other big issue here is that patients in other cultures often hold cultural beliefs about medicines that really further cloud their understanding. It may be that big pills are for big people and little pills are for children. Red pills are for blood problems, blue pills are for stomach problems. I have seen all of these belief systems out there. You know, Don and Dawn are a physician couple that work in the Dominican Republic and have been there for years serving as missionaries, and they have written a number of articles about short-term teams coming to visit there in the Dominican Republic, and one was a study that they did on short-term projects that found that 36% of patients seen by a recent medical team had shared the medications the free medications they received with one or more people, some of which were children. You know, some basic patient safety standards are essential. One of which is these standards that I want to share with you that came directly out of World Health Organization Integrated Management of Childhood Illness Guidelines. On the WHO, it tells us that mothers of children prescribed home medication must, for every child, verbalize the medication instructions, demonstrate measuring the dose of medication, and administer the first dose of medication under the supervision of a licensed provider when possible. Private pharmacy consultation rooms. This could eliminate a lot of the pharmacy issues in medical missions. If you can't give the instructions and give the medications in the exam room, if that impedes flow too much, then we need to look at how do we give them in a private pharmacy consultation area where moms don't have to worry about, they can put 100% of their concentration in, and they can take the time to be learning about the medicines and how to give the first dose to their child. You know, Maria's story, unfortunately, is not isolated. In 1999, Operation Smile drew much public scrutiny due to charges of quote, shoddy practices. Now, I don't want to call them out individually. I think that this is a medical mission community thing, and Operation Smile's patient safety standards and guidelines have really set a great example nowadays, 2 decades later. But this was a real challenge for them. They had 4 deaths. They had 4 deaths of children in 1998, 12 in prior years. 29% of or 169 of the children whom Operation Smile operated on had major complications, required ongoing care and surgical revisions in Chinese hospitals. So it's not, this is not an unusual or isolated incident. You know, in Kenya, a child died during surgery as a result of running out of oxygen. In Vietnam, a child was lost as a result of an asthma attack during surgery. Medical history not, a medical history not uncovered in the pre-op evaluation. So all these are really challenging incidences, and but I think there's really ways to avoid them and make sure that we're doing this, our engagement in global health, well. You know, potential poisonings are another huge issue. We saw one example with the Maria story in an overdose, but you know, it's estimated that approximately 125 children die every day as a result of poisonings around the world. The vast majority of these are pharmaceutical related. And there's been a number of studies that really look at, you know, what about the polypharmacy, what about all of these issues with, you know, Ziploc baggies, and when you really compare that to the data that's really going on in child poisonings, it's really kind of frightening. You know, we found that 55% of children were, childhood poisonings were medication related, with analgesics, nonsteroidal anti-inflammatories, and antihistamines being the most common cause in the 1 to 5 age group. And there was another study done in Turkey, also showed accidental ingestions of medications was the most common cause of poisoning in children age 1 to 5 at about 57.7%. Yet another in Bangladesh, a multinational study in Bangladesh, Cambodia, Egypt, and Pakistan showed that medications were responsible for about 31% of poisonings in children under 12 years of age. And we got to remember that in prior to 1970, we were having very similar issues here in the United States, and that was prior to the Poison Protection Packaging Act. They were, prior to that time, child poisonings were a leading cause of death in the 1 to 5 age group here in the United States. The point being is that child-resistant containers are easy to obtain from pharmaceutical suppliers. They are cheap and they are lightweight, so they're easy to carry. You can carry duffel bags full of them if you're dealing with medication. There's no excuse not to use these. And oftentimes I say Ziploc baggies are not acceptable, are never acceptable for dispensing pharmaceuticals. And I would add to that only drug dealers give out medicines in Ziploc baggies, rarely do healthcare professionals. Now there's a couple other things, and we talked about patient safety, and if we look at this other pillar, that would be human dignity. And I think that probably paternalism is the greatest challenge to responding to human need. And paternalism is defined as an attitude of a person that subordinates another as if they need to be controlled in a fatherly way for their own good, right? We often see this in short-term medical programs, and it's something that we really need to pay attention to. And just being cognizant of it, I think, sometimes can alleviate a lot of paternalistic approaches. This idea of relief versus development, I think that many of us understand that relief is meant to provide short-term charity in emergency and crisis situations. Whereas development is about improving self-sufficiency and building capacity. But one thing we need to remember is that giving handouts of goods and services, even medical services, in situations that call for development can build dependence and do enormous damage to development efforts. They do this by undermining the capacity and willingness of resource-poor communities to steward their own resources. So how do we overcome this problem? That's the question we need to continue to ask ourselves. Building on existing resources and capacity is the starting place for both relief and development, and that's something that we need to keep in mind. Asset-based community development. ABCD. What does that mean? Well, let me ask you a question. If I make a list of all of the things that you need, all of the things that you lack, all of the things that you don't have, that's not a very empowering starting point, is it? However, if we flip that coin, and we say, I make a list of all of the capacities you have, all of the God-given abilities that you have, all the things that you have as resources, instead of the resources that you lack, that can become a very positive starting point, can it not? And that's the idea of asset-based community development. But we have to understand that both development and relief, they all start on the same point, that we have to start on the building of local capacity, not in doing for people what they can do for themselves. The picture that you're looking at here is actually the Catholic Cathedral in Port-au-Prince, Haiti, a couple of weeks after the 2010 earthquake. So, one diagram I use in my book to help illustrate the idea of community participation is this. This community participation ladder was originally published by Sherry Arnstein in 1969. Is a ladder of citizen participation. But essentially, this is a great, I think, example or model for medical missions, because we start in this bottom rung, especially if we're not very experienced in intercultural transactions and partnerships. We sometimes end up with this idea of manipulation. Outside people, those often with power, decide what and how to do things according to their own plans and purposes. The next rung up would be information, where people are informed of the plans and decisions and actions and their rights and responsibilities. But there's not a lot of two-way interaction or communication. The next would be this idea of consultation, where people are consulted and there is two-way communication with opportunities for input. But we're still really only about halfway up this ladder. Ultimately what we're shooting for is the top rungs, where partnership and their self-management, and people in communities initiate actions. They have ownership of those projects and programs and actions. And the power and control over the decisions belongs to the community. That's true partnership. That's true cross-cultural partnership. And that's ultimately one of the aims that we want to shoot for. But ultimately, the top rung is this independent controlled, where we decide together, acting together, responsibility for plans, decision-making, outcomes, resources are shared equally and negotiated together. And that's something that we don't see enough of. But ultimately, it's when the community really can stand and own its own projects and take control and need very little outside assistance. In the context sometimes of where this is used in refugee settings, we have to remember that many of the affected people, not only do they need to have a voice, but they need to have control of what's happening to their lives. Many are doctors, judges, nurses, engineers. It's not just the poorest of the poor. They're in refugee and crisis situations. When we're talking about this idea of community participation, one of the things that we have to remember is that oftentimes getting up that ladder is a hard thing to do for short-term programs. In fact, probably the vast majority of short-term programs operate on that lower rungs of the community participation ladder. But in trying to climb the rungs, we sometimes end up with this idea of of community participation that looks like this cartoon, which says, you know, how can we get them to do what we want? Well, why not through community participation? We can get we can get international funding for that, right? So our attempts at true participation end up looking far more like manipulation. You know, so here are some things I want to review and help you understand healthcare in the global context. And that's that in order to do this well, we have to attempt to identify potentially unintended consequences or potential unintended consequences. That's something that we always have to have our eyes open for. We have to look to the impact of all the stakeholders engaged that may be affected by a program. We have to use approaches to both relief and development that support human dignity and build on local capacity. We have to avoid paternalism, and sometimes just being aware that our actions can look that way can help us move that direction. And we have to avoid the pitfalls of unhealthy, codependent cross-cultural relationships. I want to share with you a couple of things. Medical Missions 101, this is our ministry blog. It's largely my blog. I'm taking a lot of concepts in the book and kind of breaking them down into shareable articles that folks can use to maybe help with their short-term teams. The other thing is this clinical resources page that we put up. We've tried to extrapolate a lot of information from the World Health Organization and put it all in one place. So these are these are certainly resources that are available to you. And the World Health Organization website, I don't know if you've been there, but it's really a huge, monstrous place to go and seek real certain clinical standards. So we've grouped things together in child health and maternal health, surgical standards, all of these certain things that are on this resource page. Please feel free to use it. Just go to our website at healthservicecorps.org and look for the resources tab, and you can find it, or this link will get you there, bit.ly/CHSC clinical. So in closing, I just want to kind of share, there's such a need out there in long-term missions and long-term programs. And many of the problems that we see in short-term missions could be avoided if we did one thing. And that's what we began to reshape our thinking, that our short-term efforts should serve and support long-term work. And if we continue to think that way, I think most of these problems could be avoided. There are hundreds, if not thousands, of healthcare programs, Christian mission hospitals and healthcare programs that are really fighting for survival. And we have this huge group of volunteers, you may be one of them, that are going out to provide healthcare in the developing world. But sadly, these two worlds often don't communicate. A couple of years ago, I was leaving Loma de Luz Hospital, a place where we have a number of really highly qualified medical missionaries, a number of physicians, a few nurses, nurse practitioner, PA, all of these people serving at this hospital. They have great functional surgical services, and I get about 3 miles down the road from the hospital, and there's this huge medical team setting up. So I had to stop and just ask, hey, I just wanted to say hi and ask what communication you had with the hospital down the road was. And the answer was rather challenging, because they said, what hospital? And sadly, that is so often the case in short-term medical missions versus long-term medical missions. That hospital has charts on all these people. They know these people. They're their patients in their outpatient department that sees upwards of 100 patients a day some days. But yet, this team didn't know that hospital down the road, probably the most functional hospital in Honduras, They don't know that hospital exists. So think about, in your mission work, how do we serve and support these healthcare programs so that we don't lose them? That we can come alongside them and serve and support their mission, not ours. You know, we have folks scattered, about 50 families that we're caring for now, scattered across 14 countries, and they're my heroes. That they're willing to sacrifice so much to go into these really hard places and bring their families and raise their children there. They deserve our support. They need our support. And they're not the only ones. There are so many long-term missionaries out there. So I want to implore you, just if you know long-term medical missionaries, stay in touch with them. See how what you want to do in the short term can help and serve and support what they're doing. They need people to relieve them. They need, they can use groups in certain circumstances. But it makes so much more sense if we can figure out ways to take all of this energy around global health, all of this desire to serve and support those who have need, if we can do that in a way that is constructive and supports the long-term mission hospitals and health programs that are out there really trying to survive. Anyway, I want to thank you for listening. I want to thank you for being part of this course. We hope you receive something out of this and in a number of the other presentations that are to follow. God bless you and have a great day.